Today, let's look at the shoulder more and go over a quick study that looked at what diagnoses clinicians are finding when they use repeated movement testing with patients with shoulder complaints. And of course, that's incumbent on the clinicians being reliably good at using repeated movement testing. And that's what they did in this study. They only used clinicians who have been certified or diplomaed in using MDT, the McKenzie method, which is what uses as its diagnostic process, in addition to all the other tests that we learned in orthopedics, it uses repeated movement testing. I got certified many years ago, and then I decided to pursue my diploma, which involves a semester of coursework online and then going to a clinical site to work with mentors for 9 weeks. I went to Austin, Texas, and I did all that effort because it made so much sense to me when I applied repeated movement testing with my patients and with my own disc herniation in my lumbar spine that had been plaguing me for years with episodes of severe pain and intermittent just disruption to my life. And I found using repeated movement testing so effective and so helpful in my patient care outcomes that I spent all this time and money to learn it really well. And of course, I'm still getting better at it, as any clinician does the more and more patient encounters they have. The title of this study is a prospective study of patients with shoulder pain and mechanical diagnosis and therapy, MDT, also known as the McKenzie method, at its core, repeated movement testing. It's published in 2019 in JMMT. This is the author. I don't know how to pronounce his name. So they used 4 clinics, again, with 9 clinicians, 8 physical therapists, 1 chiropractor, all highly trained in using repeated movement testing as part of their eval. That does not mean that we cannot use the empty can test or the Hawkins-Kennedy test or the liftoff test. We have those as clinicians, of course, at our disposal. We also know that for some people, emergent or quick imaging is required. So we have those tests, but we rely most heavily on repeated movement testing. So the outcomes they looked at were pain and function, and they used some form of the DASH, the disabilities of the arm, shoulder, and hand questionnaire for patients to fill out. In line with most orthopedic studies that I read, unfortunately, they are not commenting on the range of motion, strength, nerve tension, etc. So it's hard for clinicians or even patients who are reading this to glean A, the treatment, because that wasn't provided, and B, what changes in the disorder we're seeing. So we have to go on pain and function as the outcomes. Now, they were curious about the prevalence of the diagnosis. So what do clinicians who use repeated movement testing when it comes to shoulder complaints find in terms of diagnoses? And they were secondarily curious about if there was a relationship between the diagnosis and the outcome. And I'm not going to focus on that as much. I'm interested in presenting today the prevalence of the diagnoses that these clinicians found. And of those 4 clinics that they used for this study, I worked briefly for 5 months at the one in Tallahassee, Florida. So I feel like because I have this level of training and I see the same results when it comes to my patients with shoulder complaints, more or less. So what is really key here is the exclusion criteria are slim. So we're getting a wide swath of patients with shoulder complaints. But there's the 2 exclusions. One is really key in my mind. So yes, they're excluding people who had surgery in the prior year, and that makes sense. But secondly, when they did repeated movement testing of patients who walked in the door with shoulder complaints, and they did repeated movement testing of the spine, the neck and or the mid-back, the thoracic spine, and they found a relationship between the shoulder complaint and the spine, they were not included. So we're taking those people out. So we know from the XBOS study that I've commented on before, there's a large cohort of patients for whom their shoulder complaints are coming from their spine or resolved with moving their spine in a repeated direction. So in a repeated movement, or in a direction repeatedly. So they are excluded from this study, which narrows it down to people who have shoulder complaints that are probably actually coming from the shoulder. So go back to the XBOS study and you'll see that around 40% of people who complain with isolated shoulder complaints have their disorder resolved by moving the spine. And that's a huge number. So we've excluded those patients. And then they looked at the 261 consecutive patients who presented to these clinics. They got down to 223 because some people did not fill out the intake form. And then they got down to 115 for people that filled out the intake form and the discharge form. So that's the cohort of people that we're looking at here, where they have all the data that they want in order to make the study complete. So of these 115 patients with shoulder complaints, in the McKenzie method, we have a little bit different terminology, but I don't want people to get tripped up on that because it's just words. So I'll try to present this as how most clinicians would think of the shoulder. Now, of the 115, 51 were shoulder derangements. And that's obviously a term, joint derangement, and a word that other clinicians do not use. But as I've mentioned before, it's a disorder in which the joint creates local and or referred symptoms. There's limited and or painful range of motion. There's possible weakness around that joint or another area of the body, possible nerve tension, and by definition, signs and symptoms resolve by moving the joint repeatedly into its directional preference. And the top three that we see for shoulder derangements are shoulder extension, shoulder functional IR behind the back, and shoulder horizontal adduction. There are many others that we use, but those would probably at least be my top three, and I think colleagues of mine would agree. So derangement is a new word for most people, but that's what we're finding. Over 40% of patients who have shoulder complaints where it's not coming from the spine have a shoulder joint derangement, and those are typically the rapid responders. My key piece of information that I want to convey to people is that they're missing this if they're not doing repeated movement testing, and they're not going to be as confident in their other diagnoses. So if you don't do repeated movement testing, you might believe that what the MRI is showing you is exactly what's causing your symptoms. And I refute that premise. So of that 115, 26 had articular dysfunction. Articular is a fancy word for around the joint. So something around that joint, a capsule or maybe something like a ligament is restricted, it's tight. And so that patient's only going to have pain when that restriction when the patient moves into that restriction. Like they can only go this far with shoulder flexion and then it starts to hurt. So sometimes things get tight around the joint, and the care for that is just kind of stretching into that restriction. And it's a different type of treatment than repeated movement testing repeated movements into the directional preference. The third type of the 115 for diagnoses was what we call a contractile dysfunction, but what is synonymous with the tendinopathy. So tendinopathies of the rotator cuff are common. They're not half as common as a joint derangement, but they are common, and so I'm definitely on the lookout for a possible tendinopathy. And then they found 18 of the 115 were in a smaller bucket of a large number of things, which could be anything, we call it other, but it could be anything from arthritis to frozen shoulder to a true structural lesion like a slap tear or muscle tear. There's other things as well. But what I want to convey is I think we are jumping to these way too quickly in most of orthopedics. And part of that reason is because we're going to imaging way too quickly. We need imaging for the right patient, yes, but because we have so many studies that show that if you take a picture of someone's shoulder, especially someone over 30 or 40, you are going to find something in almost all cases. I am sure if you took a sophisticated image of my shoulders, you would find something not entirely normal. And the problem is, if you do that in the presence of a patient complaint, clinicians are making the leap that must be the problem. Even if it's, something major, like a major tendon rupture, it doesn't necessarily mean that it's new and or related to the patient's complaint. And that's what repeated movement testing allows me to deduce much better than I used to before I used repeated movement testing. I can tell if there's already been an MRI, which hopefully there hasn't, unless it was a major trauma. I can tell if the MRI is telling me something useful or something incidental. Oh, you have some rotator cuff tearing or fraying, or the biceps is shows some signs of tendinosis, but it's not relevant. And a lot of people have these things, is not to worry. So MRIs, there's several problems with doing them prematurely. One, it delays, effective care if you're spending time and money on the imaging instead of getting a good repeated movement exam. Two, patients, unfortunately, because clinicians do this, they're learning from clinicians, they're learning from the American, healthcare sphere. Patients will latch on to the problem. Oh, I have a labral tear. Oh, I have severe bone on bone. And we don't want them to do that because that creates a lot of fear for people. Versus if I got it, I'd just be curious what's there, but I'm not going to fret over what we would find because I know that my shoulders are fine. I do regular weightlifting, I have full range of motion, and I don't have any problems with life. But you would probably find something there. And the fear is that patients latch onto that. Not only does it create fear in that patient's mind sometimes, but it leads them down the wrong path of treatment. And then thirdly, of course, the MRIs cost a lot of money. And getting into the cost assessment of all these things is, kind of futile because there's no free market for these things. Costs are severely, conflated based on many different factors in American healthcare. But we don't need to be spending $500 to $1,500 on an MRI when the clinician can just use her brain in almost all cases without trauma. And patients are paying for these with their premiums and deductibles, etc. So we only need to use MRIs when absolutely necessary. And I'm afraid that a lot of clinicians are jumping there way too quickly, or even x-rays way too quickly. If you're not suspecting a fracture, we don't really need to jump to x-rays. It's only after we go through some good clinical testing over 1, 2, 3, 4 visits that we come to the conclusion, I think we need an image. We need to suss something out because it's not quite matching up with our expectations in the clinic. So I wanted to mention quickly about the secondary analysis of the diagnoses and the outcomes, that the patients with a joint derangement in their shoulder, they were discharged on average 35 days before the people in this category of dysfunction, and they were discharged on average 28 days before the people who are classified or diagnosed with one of the diagnoses in the other category. So this again corroborates what I'm seeing in the clinic, finding a ton of people with isolated shoulder complaints that are coming from the spine, either the neck or the mid-back. Another large cohort are shoulder joint derangements that can be rapidly resolved by finding the right direction the patient needs with progressive repeated movement testing and then going into that motion repeatedly. Articular dysfunctions, we're just giving you a plan of going into that restriction, stretching that tissue, whatever that tissue may be. That's pretty self-explanatory. Same with contractile tendinopathies. We are going into the load that produces the patient's symptom. It's not a lot of visits. It's just making sure that we're on the right track periodically with visits to make sure that tendon is getting the provocative load to help it remodel. And then for the slew of other people, they're getting the matched treatment that's specific to the diagnosis in that category. I have 2 other videos at least recently that I've done on the shoulder. One looks at a case series of overhead athletes diagnosed with impingement who had their shoulder symptoms and signs resolved with moving the neck. And I did another one that looked at shoulder derangements. I think I delineated 4 studies of shoulder pain that was either a shoulder derangement or a neck derangement. So feel free to look for those if you're curious about learning more about the shoulder. But the end conclusion is that I advocate for repeated movement testing of the neck, mid-back, and shoulder joint when it comes to shoulder complaints. When you do that, you find a lot are rapidly reversible by moving repeatedly into the direction that the joint needs. And for the other ones, they're getting their specific treatment, either stretching into the restriction, loading into the painful tendons load, or the specific match treatment for the many other diagnoses that present in the shoulder.